it circulates. If you look at the one they gave us the concept diagram, so it's a process of which oxygen is transported to the cell and CO2 is coming out. Okay? Antecedents. In order to happen that, we want CO2 going to the cell and whatever the waste is going out of the cell. So what we need? Think about that. We need what else?
Hemoglobin.
So heart.
Hemoglobin, because it carries O2. What is it? Oxygen, obviously, yes. So if you look at that, it's adequate functioning of respiratory system, adequate perfusion. When you say perfusion, it's the heart and the blood vessels. And also the RBC, blood. Adequate neurologic system. Why the neurological system is important? Control. It regulates all this. It regulates perfusion, it regulates respiratory. Because the level of O2 goes up, it triggers in the brain. So that's why we hypo or hyperventilate. Like when we exercise, our body needs more O2 and we start breathing more faster. Because our brain tells us that you need to get your respiration instead of 12, you need 20 now to get the same amount of oxygen, Then cardiovascular is the same with the perfusion. Efficient cellular metabolism. What does that mean? You guys know that.
What was the question?
The last one. The efficient cellular metabolism. Think about metabolism, think about O2 and CO2. The cells also need O2 to function, otherwise there will be cell death, okay? And also the metabolism, the one that converts O2 and CO2, remember we talked about lactic acid and DKA, all those acids? The end product is CO2, so those should be working normal too. The attributes, how we know that the gas exchange is normal? We look at the pH, we look at CO2, we look at the pulse ox, we look at the respiratory rate and the rhythm, that all tells us that it's working pretty good. And person is conscious and the skin color is good. What happens if we have impaired gas exchange to the skin color? Bluish. Okay, it can be a bluish from poor perfusion and also lack of oxygen. So when you look at the sub-concepts, so it starts with the inhalation and exhalation. You inhale, then you exhale. Is it working?
Yeah.
I'll leave it like that for a while.
I don't know how long it lasts. We've got it.
That's okay. Because this is more brighter as compared to the other one. Yeah. Thank you.
This one actually look better over here today.
It does.
I don't know what
In the sub-concept, I also want you to think about your whole respiratory system. Okay, like from top to bottom, where it goes. Goes through your mouth or your nose, then your pharynx, okay? Then it goes larynx, trachea, then bronchus, then bronchioles, okay? Then finally, where does it go in alveoli? Alveoli is the one that's where, I don't know if this works. So they are like this. The alveoli is the one that's where the gas exchange happens. Then you have your capillaries. So they put CO2 in here from the blood, okay? Then this one gives O2. So this is your alveoli. That's where the gas exchange happens. In order for the gas exchange to happen, so alveoli, they should be like a vacuum, like open. So they can get the air because it's like a balloon. Okay? It goes more, goes less. Okay? In gas exchange, we were looking at the conditions that block those alveoli. Okay, either they're congested, or they're filled with pus, or they're filled with infection, okay, or they are just inflamed from allergens. Okay? In those conditions, they don't have much space that they needed to exchange gas. because they're filled with some other stuff. Okay? So that's why gas exchange is getting affected by pneumonia, by COPD, by asthma, by RSV, that's what we're going to talk about. So all these, they either cause infection, okay, block the alveoli, or in certain diseases, they cause inflammation, like in asthma. Okay, the walls become thicker and they're not effective to get the CO2 out. Then we'll be talking about tracheoesophageal fistula. Okay, anybody knows what that is? What is trachea? Trachea, esophagus, fistula. There's a hole between them. You know, so there's a hole between your trachea and esophagus. What happens? Because if you look at the concept, it's not normal functioning. In the adequate functioning of respiratory system, the anatomy of respiratory system is wrong. Okay, so the gas exchange is impaired. So then if you look at the oxygen carrying capacity, that's what you guys were talking about, your hemoglobin. Okay? Oxygen is carried through the whole body with the hemoglobin, with the red blood cells. Okay? Then circulation, that's where perfusion comes. If you have any circulation problem, anywhere is a clot, anywhere something going on, so you won't be able to circulate the blood to the parts of the body. Okay? So that's also very important. When we say sub-concepts, those are the things that gas exchange cannot work without. Gas exchange cannot happen without inhalation, exhalation. It cannot happen without oxygen carrying capacity. It also cannot happen if you don't have a adequate circulation. We must need those for the gas exchange to happen. Okay. And the next one is if you look at the positive and the negative. Okay. The positive will be eupnea, just like your normal respiration, age-appropriate mobility, capillary refill, and age-appropriate response to environment. That we are alert or rated times 4. Negatives, you can have a respiratory compromise, respiratory failure, respiratory distress, then altered oxygen carrying capacity, you can have hypoxemia, low oxygen in the blood, you can have altered mental status and anoxia. Okay. And what is anoxia?
Without air.
Absence of oxygen, and hypoxia is low oxygen. Then the VQ match, that's your ventricular, ventilation question mark, so that will be mismatched too. Okay? So it's usually between your inhalation and your exhalation. The interrelated concept. These concept does not directly affect the gas exchange, but if something happens with that, it can affect the gas exchange too. Like they're related, you know. So mobility. What happens? How can mobility affect your gas exchange?
Lack of mobility decreases.
What is it?
Lack of mobility decreases.
Lack of mobility can do what?
Decreases. It can decrease the oxygen.
Yeah, if you're not, lack of mobility decreases your oxygen consumption. Okay? The other thing is if you're exercising, mobility more, you need more oxygen. The other thing, mobility is important after surgery. You know, after surgery, why mobility is important? If you don't tell person to walk, they can have walk, coughing, deep breathing, that helps to prevent pneumonia. So mobility is important. Coughing. How coughing is associated with your gas exchange? Think about you're out of breath all the time.
Coughing helps.
What?
When you cough, it helps. Like if you have something in your lungs, it helps.
No, coping. Coping, the concept of coping.
So I guess if you are,
You'll be under stress.
you're breathing faster.
You breathe fast.
Or you
Okay?
can be breathing.
You have hypoventilation, hyperventilation, that's going to affect your gas exchange. You know? The other thing is, think about your stress hormones. Okay? They either can cause more CO2 or the less CO2. So that affects too. The other thing is coping is also related with the chronic gas exchange problems. If somebody has a chronic COPD, chronic obstructive pulmonary disease, for a long time, or they're in stage 3 and 4, they will have coping issues, because it's a chronic. That's being a chronic issue. Then acid base, we all know that, okay? CO2, bicarb, those are all important. Perfusion, yes, we're going to discuss more next. Nutrition, what is the role of nutrition? How is nutrition related to gas exchange? Look at the last one in the antioxidants. For cellular metabolism, we need nutrition. You know, you need protein, you need amino acids. Okay, you need all the phospholipids for the cells to work properly. Okay? And let's see, I think we don't have any diet restrictions in any of them. So nutrition only helps with the cellular metabolism level. Okay? In other concepts, nutrition might be related to the diet, like in a diabetic diet. Okay, so here nutrition is more with the cellular activity. Any questions on it? So you know that, so here, I'm just going to put, you inhale coming from nose, all the O2 is coming here, O2 coming here, okay? So in the alveoli, then you have that little capillaries, so they carry, I wish I have a, so this is like, I'm going to say it's a red, okay, so that means they carry the oxygenation. And then the other will be a blue, so that means it's getting the CO2 out, and it's getting out through. So that's why basically the gas stage all happens in the alveoli, okay? But this is all like an air, but if I fill this up in pneumonia, what is happening? It will be impaired. We do have like it's a gazillion probably alveoli in there, but your frequency will decrease. Okay, you don't definitely look at how much pneumonia is. There's a lateral, bilateral, bilateral. So you might have heard that doctor says if you have a unilateral pneumonia, it's not that severe, but if you have bilateral, it's more severe because your alveoli are more involved. Okay, we'll be talking about asthma. How much do you know asthma? What is asthma?
Wheezing.
What?
Wheezing.
Wheezing, yes.
Hyperventilating.
Decrease oxygen, what else? Inflammation. Why there is inflammation? It's also called like a reactive airway disease. Okay. It started as a reactive airway disease because the body is hypersensitive to some allergens. Okay, so it's a hypersensitivity response. So we also talk about greater immunity in asthma too, okay? Because immunity plays a role. So our body, people who have asthma, their body is sensitive to certain pollens. So if you look at the So if you look at the asthma, okay, one is the normal. Here, this is your normal, like human, so there's no inflammation, okay? The membrane is all intact and there's a big kind of a hole. But here, what happens when we talk about immunity, the immune cascade system, okay, that's the one that responds, okay? We have histamine. Remember, that's why we take antihistamines, because histamine is the one that gives us response. Like anytime you come with allergic reaction, the body produces histamine. That's when you start having sneezing and all that stuff, because histamine tells the body that this is something foreign, okay? Then the mast cells get stimulated, okay? So when there's a degranulation of mast cells, smooth muscle constriction, mucus plug, mucus stimulation, so they all cause inflammation. That's what happens in asthma. Okay, now here you see that mucus plug. from the inflammation because all that debris that need to go somewhere. Okay, so then mucus accumulation. So think about gas exchange happening here. It's going to be impaired. Okay. So it's a chronic inflammatory disorder. That's why we call it inflammatory, because it is your body's response to a foreign particle. It can be a pollen, it can be a dust, it can be a trees, okay? A lot of people can be for animals. So asthma triggers are, so it's a hyper responsiveness. So you might hear in hypersensitivity in immunity. So that's why immunity and gas exchange kind of go together in some of the receptors. It's reversible. There's some people, they have asthma like for 10 to 12 years, okay? All of a sudden, if you move to another place or they can get over with it too. So inflammation with recurrent episodes of. So that's when we call that asthma attacks. Okay, when we talk about asthma attacks, we look at the shortness of breath, we look at the difficulty breathing, chest tightness and chest pressure, okay, and then coughing, especially at night. Okay, why coughing at night is more prevalent?
You're laying
Because
flat.
you're lying in position, you're not sitting up, so you don't have enough space, okay, and wheezing.
Yeah.
Mild episodes that can be treated at home, and it resolves sometimes spontaneously. And most attacks, like they're not mild, they require immediate treatment. What is the treatment for asthma?
Albuterol or steroids.
Albuterol, salmeterol, I heard that.
Mm-hmm.
What else? What categories are those?
Bronchodilators.
Bronchodilators,
Mm-hmm.
okay? Do you guys do
Steroids.
short-term and long-term? Short-term bronchodilators and long-term? Okay, we'll talk about that.
Yeah.
That's all we're going to talk about in COPD and asthma, okay? Those medications are kind of a same for both. Okay? So if you look at the pathophysiology here, okay, the trigger factor, like we said, is the immune activation of the mast cell degranulation by your histamine. When you are allergic to something, the histamine gets message to the mast cells, then there is the airway inflammation. And this inflammation is the one that leads to hypersecretion, air muscle constriction, and swelling of the bronchial membranes. Okay? What happened? Like we went to this passage. See, this is the normal, this is asthmatic, this is during the attack. Okay? So you see that how constricted it is. Think about the airway, just we think about the coronary artery disease, where there is a fat accumulation in the coronary arteries, you have less lumen. So same thing here, you have a smaller lumen, so you have smaller passages for gas exchange. Okay. So this all leads to limiting airflow, and these are the clinical manifestations that you can see it when there's a narrowing. That's where the wheezing comes from. Try to see it. If you blow in a pipe, it's different. But if you blow in a pipe, if you hold it constricted, you'll hear that noise. So that's what the wheezing we hear it. So when we hear the wheezing, because that air is going through those constricted air passages, okay? Status asthmatic. What is status asthmatic? Have you ever seen it? It's like a status epilepticus. Like a constant seizures, one over the other, same thing here. They are having an attack, it's more severe, okay, and it's not controlled by any bronchodilators or anything. And that if you don't pay attention, any person who comes in a status asthmatic is a medical emergency. Okay, if it remains untreated, person can go into respiratory distress and respiratory failure. So risk factors, we all know that, common allergens. Okay, so there will be a people who's allergic to everything. So here in dialysis works. Air pollutants. Drugs, exercise, stress. Sometimes the kids, they get the stress-induced asthma. So that's why some of the doctors, they tell you to take a 1 puff or 2 puff of salbutamol before they do the physical activity or any kind of exercise. Genetic. Okay, there is a genetic relationship with asthma. If there's a family history, it's more chances that you will develop asthma too. That has to do do with your hypersensitive response to immunity. Okay? So not because some other, like I said, like transfer from gene to gene, there is no gene transfer, but there is a hypersensitivity. You know, just like the cancer markers. In some families they run. So here in the immune system, so you might have a hyper response. Occupational asthma can be some people working in a paint and fumes, all those industries. So risk factors in child. When we talk about child, we talk about virus. You know, kids bring so many virus and all those boogers. RSV, oh God, I know, the kids, you know. RSV, parainfluenza, adenovirus, mycoplasma, chlamydia. So those are the common ones that causes asthma attacks sometimes to the kids. Obesity can do that, okay? What did you say?
Chlamydia? The
Don't be
STD?
surprised. What?
The STD?
Chlamydia is trichomonas, yes.
Yeah, the bacteria, I've never.
Yeah, it's a bacterial.
Pseudomonas.
So these are like, these are diseases, it's exposure. If the mom has chlamydia, look at that exposure to the infections in the early life. Okay, that increase, it's not like a cure. Come on. It's exposure to those diseases, okay? Like RSV does not cause asthma, okay? But if somebody has a RSV, they're exposed to it, they will be at the more risk for developing asthma, they will.
So if the baby's exposed to
Chlamydia.
chlamydia through the birth canal and they inhale it, is that what?
Yes, in the birth canal, yes. So they're at the more risk. Obesity, maternal smoking, and premature birth. Premature birth is, we usually call that like in the later years of the life after 32 to 36 weeks, your lungs develop and you have that coating on the inside the wall surfactant. So that gets more and more as you grow. In the preterm, they lack that. Okay? So that's why it puts them in the risk for prevention. Best thing is we're going to tell them if you're allergic to dollars, move to California. So avoiding allergen triggers, that's a good one. But majority of the people, they can't. You know? I mean, modifying home environment, you can do that. Right now, I think there's a lot of, they call it air purifier. So you keep it in the, it gives you the red light and green light, tells you how much is it. Because I have pets at home, so I have 2 of them. Wearing mask while exercising in cold weather. Why? Humidify, you know, remember our normal breathing. So when you think about when we breathe through nose, okay? The air gets a little warmer, okay, and it gets filtered with this air. So we do not do good with the cold air. The body needs a little bit warmer air. If cold air can trigger, it's like allergic response too. Okay? Some people, if they go on the high altitude, sometimes people don't have asthma, but if they go skiing, they can have asthmatic attack. Early treatment of respiratory infection is very important. Adherence to the medications. Okay? If somebody has asthma, doctor tells you to take a medication, you don't just stop it after you stop breathing. Okay? Some of your long term, you have to take it every day. Okay? Clinical manifestation, those are the common ones. Okay? Coughing, wheezing, tightness, tachypnea, tachycardia, anxiety and apprehension. Serious attacks, you might start seeing, think about that, it's affecting your gas exchange, affecting your respiration. Okay? The more serious your respirations are getting, serious attack is. Like they started breathing harder, but it's that much harder that you can see their accessory muscle used, all their neck and range used. So that means it's getting severe. In the younger kids, like infants, you can see the retractions. So retractions are more visible in the infants and the kids. Okay. Activity intolerance and fatigue, those are just common associated with it. So usually this is what they use, it calls the asthma traffic signal. So that's what as nurses or as providers, you give the education to the patient. Okay. They can upload it, they can download it from so many websites. So what does that mean? What do those lights mean? Green, yellow, and red.
Just the zones.
What level they're at.
What?
What zones they're in, like if they're in
So
the.
you know if somebody is, look at that, there's so much stuff going on in the green zone, okay? Person is already diagnosed with asthma, okay? Their PEFR is 80 to 100%, the expiratory volume, the how much they take it out, okay? That's how we measure it. In COPD and in asthma, okay, person's capacity to blow CO2 out decreases. Okay? Like they're not able to blow CO2 out like normal person, they retain CO2. Okay? That is measured by the expiratory rate. Okay? So how much is in there? So here, like it's under control, person has no symptoms, okay? Continue to avoid triggers, and they probably just have to use as needed albuterol. Okay? In the yellow zone, they start having some symptoms, okay? Give medication per plan, contact parent, stay away from triggers, monitor child. Okay? We're still monitoring in the yellow zone, okay? But their PFR is 50 to 80. If they're in red zone, they're dangerous. They better not be in the home, better not be in the clinic, so they should be taken to the hospital at that time. Okay? So that's how they make an action plan. So action plan is based on the symptoms, based on their PEFR. Okay? So that's how you tell it. And on the other side, it just tell you the normal PFRs, you don't need to remember those. Okay? You don't need to, because everybody, when you do that, with that PFR machine, they have the card that comes with it. Okay? Only thing you have to remember in normal is 80 to 100%. Okay? It may vary for different people. Okay? 50 to 80 is yellow and less than 50 is red.
And you're talking about like their average peak flow, the PEFR,
The
but
peak
their.
flow, yeah. It's a peak expiratory flow rate. Okay, let's see.
Can't hear that.
So this is a peak flow, and I'm going to show you how it works. If I can get the volume.
The peak flow? For 6 and up. If they're younger. 6 and up, they can do this for longer.
Yeah.
That goes up to 385, and the other one goes 25 or something like that. 8 something.
Close your lips tightly around the mouthpiece. In one breath, blow out as far and as quickly as possible, like you're blowing out candles on a birthday cake.
That's on
Water
both.
should move along the upward scale.
I would thought it would do
Upward in your peak flow
if they're
diet.
little.
Thank you for viewing this video from the American Lung Association.
So this is a peak flow meter, you see that, okay? I guess maybe you can hear it better at home. So you can see that here too. So it tells them to blow hard, okay? Like as much as you CO2, you can take it out. That's why we call it a best value. You take it a best, you take 3 of them at a time, okay? You take the readings at 3 different times and take the best one, okay? Like I'll give you a flow meter, you're going to blow into it, okay? Let's see, it's a 400, okay? Next one is a 425. Your last one is 475. So my best will be 475. So I'll be comparing with that, okay? So when I'm going to make the asthma plan for you guys, I'm going to be looking at is it 18 to 100% within the 475, okay? classification. So asthma is intermittent, that like comes and goes, maybe with exercise or maybe when you go to the high altitude in the cold environment, and persistent. Persistent is the one. What is going on? Maybe I need to turn the blue one off. So when somebody has a persistent asthma, like they're getting almost every day or more than twice a week, okay, then we have mild, moderate, and severe. Okay, so we will see it how we classify those, what numbers, okay. Usually mild, moderate, we look at the how many times in a week, how many times at night they're having cough and wheezing. Then acute, that's when they are having asthmatic attacks. So here is the classification if you look at it, okay? So like I said, look at the intermittent, it's less than or equal to 2 days a week, you know? Like they don't have too many in a week, okay? So you call it an intermittent. At the night time, same thing. I call it a rule of 2. Remember 2. 2 or less. 2 or less in a month, nighttime awakenings. Less than 2 days a week, they use their short acting. Short acting is the one that's albuterol. Okay? Albuterol is your short acting. That's what the one that you use it as needed only. Interference with normal activity, none. Okay, look at that lung function. So it's between 80 to 100. You know, the peak flow volume. And in the mild, now this is the persistent. Anytime somebody is having attacks more than 2 days, we call it a persistent. In a week. Okay. More than 2 days is persistent, less than 2 days is intermittent, and persistent is again divided into mild, moderate, and severe. Okay. In a mild, look at that, it's more than 2 days, but not daily. Maybe 3 days, 4 days, 5 days. Okay. In moderate, it's daily. In severe, it's throughout the day. So see that how the differentiation is done. Nighttime 3 to 4 times, more than 1 a week, and often 7 times a week. So you see that these are the probably you need to remember symptoms, nighttime awakening, and how many times they use the albuterol inhaler. So if you have somebody, a kid, if you're working as a school nurse, okay, so these are the things you want to ask the parent. Okay. How many times they use the inhaler this week? Okay. How many times? That way you can keep a track where they are. And that's what as nurses we teach the parents too. Okay. So here, like so that the severe the disease is becoming, what is happening to the mobility? It's decreasing. Okay, because person is gasping for air, they're not getting their CO2 out. There's no proper gas exchange. So it's affecting their activity. So it's limiting their activities. So in the mind, it's a minor. Here is probably some, and is here activity is extremely limited. Have you seen in the school sometimes the kids, I think they make them run in those, what do you call it, athletic fields? So they will be coming, they will be breathing like this. So that's the typical tripod position. So that when they do this, it pushes your diaphragm up, it's trying to get the CO2 out. Because it gives them relief, that's why they're in a tripod position. So they breathe like this. Okay, so tripod position is most important with both COPD and in asthma. So this position, they're trying to get the CO2 out. So same thing here, this is based on your peak expiratory flow. Tripoding, prominent wheezing. Sometimes the wheezing in severe attacks, you can hear it, you know. It's not not in the lungs, you can hear they have all the way into their bronchus and trachea, you can hear their breathing. More than 30 minutes respiration, more than 120 pulse, accessory muscle, they're agitated. Percussion. What is percussion? Okay, you hear hyperresonance. Remember, the more hollow thing is, the more sound you hear it, So that's what the percussion is. Why they have more hollowness? Because of too much CO2. Okay, so it's more air in there. Then auscultation, obviously, inspiratory and expiratory. If somebody has a intermittent, like they don't have a persistent, you might just hear expiratory wheezing, no inspiratory. So it also depends. Sputum is thick, stringy, and mucousy because of inflammation. Okay, because the body is trying to get rid of all this debris that's formed by degranulation of the mast cells. So management, what is happening here? O2 monitoring, supplemental O2, hyperventilation. So your PCO2 will be high because you are keeping the PCO2 inside. Okay. Then airflow limitation, respiratory acidosis. Is it the same? Your arrows go up and down on your PowerPoint too?
Mm-hmm.
Yeah.
This is my computer. I use the Mac at home and I have different over here. It changes. It does ask me if change. So hyperventilation, hypoxemic pH. Okay, let's do that. Move this here. So it means pH CO2 is high, pH is low. No, PCO2 is low, pH is high in respiratory alkalosis. Then your PCO2 is high in respiratory acidosis. Move the arrow a little bit on the side. Okay, one arrow goes in front of PCO2, the other one goes in front of pH. Okay, in hyperventilation, you guys know after this now, so you probably can fix those arrows. In hyperventilation, you are in respiratory alkalosis. Okay, if there is a hypoventilation because of airflow limitation, you are in respiratory acidosis. Then inhalation, what is SABAs? Short-acting bronchodilators. Okay, get used to it. When you go in the hospitals, okay, and you will hear SABAs, you call it SABAs, and you will hear LABAs. So this is a long-acting, and the other one is a short-acting. Short-acting, we give it for immediate, for as needed. Long-acting, we use it along the day. Then you have complement. Complement is a combination. It's a ipratropium and a albuterol. Then they can also do the corticosteroids too.
Is that
Okay.
the rule then?
We know that steroids works for everything.
Mm-hmm.
You know. What is silent chest? That's very important. Okay. When person is wheezing and all of a sudden they stop wheezing, okay, that means there is no airflow going on. So it's silent chest. So don't think that wheezing stopped because it's an indication that person is getting better. Also think about it can be a silent chest because there is nothing happening in that. So that means worsening of asthma. So this is like a life-threatening, may require mechanical ventilation, severe obstruction. Person might need magnesium sulfate, intubation, 100% O2, and they are nebulized with SABA. Sometimes you will see the respiratory people, they come and put the continuous albuterol. So in order to get them out of a status asthmaticus and also the severe attack in the silent chest. Usually antibiotic and chest therapy is not recommended unless, come on,
Severe?
unless,
Unless it's severe or
no.
some type of
When do you recommend antibiotics?
pneumonia.
Until there is evidence of infection. Okay, because asthma puts you at the risk for pneumonia too. If you have those secretions in there for a long time, person can develop hospital-acquired or community-acquired pneumonia. Okay, So antibiotic chest physiotherapy is normally not recommended for asthma, okay? But if somebody has infection, so then you're going to give antibiotics. Epinephrine only for anaphylaxis. Okay, you don't want to give epinephrine because it can constrict more. But if somebody has an anaphylactic, okay, you have to give epinephrine. Then bronchial thermoplastic. Is bronchial thermoplastic, they just warm up your street, okay, breathing in the air and the oxygen. Okay, so that's what is a bronchial thermoplastic. These are the complications of asthma: status epilepticus, severe, life-threatening, unresponsive to usual treatment, risk for respiratory failure. Diagnostic tests, that's your PEFR, peak expiratory flow rate, allergy testing. Other test is your CBC, ABGs, pulmonary function test, X-rays, O2 sets, and transcutaneous O2 and carbon dioxide monitoring. So these are the medications. Usually I don't want you to be huffing and puffing and seeing that there are so many COPD and asthma. Kind of a similar medication. So I want you to put both side by side when you study it. Okay. So the medication, majority of the time we use the bronchodilators. Okay. Then anti-inflammatory, combination, and monoclonal. Okay. So these are the main 4 categories that we use in both of those disorders. When we talk about bronchodilators, now I'm going to tell you SABA. It's a short-acting beta-adrenergic agonistic drugs. So it's a short-acting beta-agonistic. Okay, so that's your SABA. Then your long-acting one is a salmeterol and formoterol. Albuterol is your short-acting. Then anticholinergic. Anticholinergic is your muscarinic antagonistics. You call it SAMA and LAMA. Okay. SA in both is short-acting, LA is long-acting. The BA is your beta-adrenergic. Okay, that's a BA, beta-adrenergic. Then your MA is your muscarinic antagonistics. Okay, so I usually say SABAs and LABAs and SAMAs and LAMAs. Then this is a methylxanthine derivative. We have used this a lot in older times, theophylline, but it has came up with a lot of side effects these days, so it's not preferred. Before we have albuterol, so we used to give back home in India to the kids the theophylline in the inhalers too. So, but you won't see, I don't know, maybe if you're the elderly patient, you see they are put on the theophylline elderly, but I have never seen anybody on theophylline here. Have you guys? You have seen theophylline? Yeah, is it a tablet? It's a small white tablet, isn't it? Yeah. So you see that it's not that common. The common ones are these, you see that. So I think these all will be on your test. Okay, because they both cover COPD and your asthma. Then anti-inflammatory. When we say anti-inflammatory, there's 2 categories. Steroids, that's like a glue. There's like a glue for the inflammation. Okay. And then the other one is the leukotriene modifiers. That's your singular. Okay, here is your Montelukast. Okay. Leukotriene modifier, it works at the 2nd level. It works different than the antihistamine. If you look at your immunity, concept of your immunity, you see that there's so many different levels, histamine, mast cells, then the leukotriene, okay? So the one we take in antihistamine, they work at the level, okay, when to release, to block the release of the histamine, but this one, they work like a further, okay? So they can be, if the patient asks you, they can be both on antihistamine and the singular, okay? Because they work totally different, but they give you the same result. Then we have over here combinations. Okay, this is the inhaled corticosteroids and your SABA, or your inhaled corticosteroids and your LABA. Okay, so they are combined. So like we say Advair, okay, flucloxazine is only your ICS. Then monoclonal antibodies, these work on your immune system to make it more stronger, okay, not too hypersensitive. So those are your immunotherapies. All your MUAB, if you see those MUAB, those are all your immunotherapy drugs, okay? These are the quick relief. Okay, if somebody needs the quick relief, usually we use your SABAs, SAMAs. You can use the theophylline, and you can use these are the quick relief. Okay, quick relief. You can't tell a person to take these every single day. Okay. Usually these are the ones taken when there's a acute attack. So because they're short acting. This is a short acting. This is short acting, and this is your theophylline, and this is your systemic. So the long term, you see the long term is all your long acting ones. So corticosteroids, inhaled, leukotriene, monoclonal. So these are your long acting. If your doctor puts you on Advair, I'm going to give you an example. And if they put you on Advair, that means you're going to tell the parent or the patient to take it twice a day. Okay, no matter what. They have wheezing or no wheezing, nothing, they have to take twice a day because it's a long acting. It prevents asthmatic attacks. But they can still take their albuterol in between. Bronchodilator, same thing, long acting, and anticholinergic, the ipratropium. So those are all your long acting. So there's a take home point is long acting is used every single day. Short acting only used when there's a acute attack. You don't need to remember this. This is more for providers. So, but you can see it, how they follow the approach, like from one step to another step. Okay. As nurses, we need to know if somebody is with the intermittent, okay, what are you going to do? Just as we did albuterol, short acting. Okay. So if person moves to the next level, so then they may give you a low dose ICH, like take Advil once a day and use albuterol as we do. So as nurses, you just need to know, like if somebody is at this level and they're not getting better, what are you going to expect the doctor to order? Add a long acting or add a anti-inflammatory. Okay? If your person is already on this, so this is going you are going to expect in step 3. If your person is already on these, so that's how it goes. This is approach, stepwise approach. Yep. It's just like giving pain medication. Somebody from 1 to 4 Tylenol, 4 to 6, you go a little bit farther, then it's 6 to 10 morphine IV. Okay? So same thing, this is a stepwise approach. So these are some of the various devices. Okay? Did you do the ATI skills? Did you see the ATI skills video? Did you watch those? You haven't watched any ATI skills video?
UTI?
You guys probably know these. How to give the nebulizers and all that. You have seen it. If some of you not in the practice or they are think that they need a review, how to do the meter dose inhalers, how to do the nebulizers, in the ATI skills videos, you can go and see it. Okay, there's a video, it says ATI skills video. So you can see those. And because this is very important, the nurses get to teach the patient. And you need to know how to do these. Okay. So like this one is a spacer. You know, in the kids, we use spacer. Okay. So you tell them to count and the spacer, and this is the one that goes in the continuous on the like face mask. This is the dry powder one, the one I was talking about Advair. Okay. So based on severity, that's the one how we take care of them. Same thing. Mild usually at home. Okay. Moderate requires office or ED visit. So severe usually is an ED visit and they're likely hospitalized. So just focus on that and see it, how it's done. In the children, they require prompt treatment. Why?
They can go
You
from
can't
quick.
delay it. What?
They can go from here to really quick. I say they
go
go quick.
They can go quickly, you know, I mean, they can progress from mild to almost to severe. They won't give you time to go like a little bit because their airways are so small, okay, and they get constricted so quickly. And here, look at that, we are teaching all this to parents. Okay. At what age you think the child can start doing their inhaler on, not the, based on the developmental age.
Like
What
12,
age is it?
like 12 or 13.
Preschool or school age? School age.
School age?
Probably the school age until that time, some of the school age children you have to see it and their developmental level. So until then you use the face mask. Okay? Then around the school age, I think the parents start sending them with albuterol inhaler. So that's what the school nurse, as a school nurse, will do it. So if you work as a school nurse, so you need to make sure there's a written action plan from the provider. Okay? Even though we work in a school, we cannot administer anything without orders. Same thing, we require orders. So that's what you need to make sure that you get that. Over here, look at that. If they're more than 7-year-old, they can use metered dose inhalers, okay, the one we were talking about. 4 to 7 chamber or a spacer, okay, the one that comes with a little pipe thing. Less than 4 spacer with mask, okay, so it's a spacer, then there's a mask on the top, okay. So nebulizers for very young children, so use the nebulizers on those. So you need to know these, okay, because this is our nursing intervention. Nobody's going to tell us, so doctor is going to write the order. Now you have to decide it. So asthma in children. So I want you to watch, this is a 24 minutes video. Okay, if you watch it, it will show you throughout the patient coming with asthma, administering the medication. It's really a very good learning tool. And I want you to think about that, how your practice has changed. Watch that video.
We don't have it.
We don't have that particular.
I'm going to put it separate.
Uh-oh.
Yeah. I put it in here so I don't forget it,
Oh, gotcha.
to remind myself. So I'm going to give it to you. So this was one of my learning activities. I don't know, how do you do the learning activities? So we used to watch video together in the learning activity. Then we will go over the whole case scenario. So this is a really good one. Because we don't discuss children enough. You can see a real life children in here that are going through asthmatic attacks. How to use spacers? I'm not going to go on each of them, but you need to know. You might have some questions related to how are you going to teach, how the parents know that they understood the teaching. Okay? So it's very important. You can tell them how this medication to take, but if they're not taking properly, the medication is not going to do anything. Okay? So it's very important to tell them, okay? And wait. Don't just do two together. They have to wait in between. In pregnancy, so you must see some pregnant women with asthma too. So pregnancy usually sometimes is, here I say the rule of third, 1/3. 1/3 improves, 1/3 stays same, 1/3 gets worse. Okay. So it's highest between 24 to 36 weeks. Why? Obesity pushing it up. So it's just like giving less space in the thoracic cavity. So there is a high risk for preeclampsia, uterine hemorrhage. They're all associated with low oxygen, low CO2. If somebody is asthmatic during pregnancy and they're not treated, okay, so it can affect them too and also their babies too. So the babies can get premature birth and low birth weight. Everybody knows what is hyperemesis gravidarum? Excess vomiting in the pregnancy. Preeclampsia, high blood pressure, protein in the urine, okay? And uterine hemorrhage, that's like a postpartum hemorrhage. Increased risk for cleft lip and cleft palate. So that's also associated with hypoxia or anoxia. And use of epinephrine should be avoided. Only unless the person is like, this is a really like a risk and benefit. You have to really see it, okay? Because if you use the epinephrine, the fetus might die too, because there's no perfusion. So here there's a really, I think the pulmonologist and the OB/GYN, they both make a decision on that one. Older adults, so usually often undiagnosed. So difficult to differentiate symptoms. Remember in elderly, have you learned in human development the changes that come in the thoracic cavity? It becomes like a pigeon shape and all that stuff. Okay. So if sometimes people think that those are age associated, sometimes if you get the barrel chest, it might be related to your COPD. Because you're having too much O2 and it's expanding, so it gives you a barrel chest. Okay. And factors in development of asthma can be related to lungs or maybe immune changes. Like I said, it's a hypersensitivity response. High morbidity in elderly, multiple diseases and drugs. The other thing is we have to always keep in mind if you're prescribing any kind of treatment or any new medication with the elderly, always check drug-to-drug interaction. Majority of the elderly people, we have to worry about polypharmacy. You know, there might be at least 2 or 3 drugs. I think the rest of the stuff is that you probably have heard all that in human development. We have to worry about their financial compliance and health, you know, and if they're able to manage self or they need a caregiver or they have somebody or not. Nursing assessment, this is you're more focused on your respiratory. Most important is your PEFR log, okay? So if somebody is a newly diagnosed, they send home, okay? So that's what you want to make sure that they know how to use the peak flow, and they need to keep a record of it. Okay? So sometimes your doctor, that's how they evaluate if you're getting better or worse to make a treatment plan. The rest of the stuff you you guys do admission? Like you can do the admission when the person comes there. You ask them the chief complaint, why they are here, physical symptoms and all that stuff. So those are your normal, but you more focus on over here, like what caused it, okay, what were they doing, or what is their previous medication they're taking. So those are some of the important things that we need to remember if we're taking history from an asthmatic patient. Physical exam, so what will you hear in auscultation?
Wheezing.
What is your physical exam when you auscultate the lungs for the person who has asthma? Wheezing. Inspiratory or expiratory? Both. Can be both. Okay. Palpation. When you palpate, can you hear something, vibration or anything? Maybe it depends on how bad their respirations are. Apical pulse, tachycardic, okay. Skin color can be normal, can be bluish, okay. Level of consciousness depending on the distress. Okay. So when you focus on this, just don't look at this. We don't care about, if I say that what is nurse's important assessment, we're not going to say vital sign. It's your respiration. Okay? So looking at the both can look what associated with the skin color. What are you looking for? You know? These are your nursing diagnoses that can be made. Okay. Also, which one is the priority out of the top 3? Out of the top 3, which one you're going to do take care of first? Airway clearance, then breathing, then gas exchange. Think about that when you make priority, like you want this clear, okay? Then to move it further, you need a normal respiration, then you focus on the gas exchange. Okay? The planning depends upon the sign and symptoms and the severity and the history with the person. So these are some of the things that you can do. This is a position usually to breathe better, even in COPD and in asthma. Okay. And Fowler's, high Fowler's or orthopneic. This is orthopneic position. Okay. So Fowler and high Fowler, you guys know that. Oxygen, respiratory, help relieve anxiety. Okay. That's where your coping comes. If somebody's out of breath, so they were anxious, you know. Like you can't catch breath. So this is like a circle. You can't catch breath, you get anxious, then your breathing becomes worse. So that's why you wanna make sure that they, hold on. So that's why you wanna make sure that you relieve anxiety and use some of your coping mechanisms. Promote adherence to therapeutic regime. Very, very important to tell the asthmatic patient and or if it's a child, their parents, once the wheezing stops or the child starts feeling better, do not stop any of the medication until they're reevaluated by the physician or seen by somebody. Yeah. Because when they put you on a regime sometimes, so you have to have like one in the morning, one at night, so you say that, okay, it's getting better, I'm going to stop these. Eventually, you might get it to that point, so that's what we want the parents to be go, where they can switch back and forth between it and start using albuterol as needed only. So that's where we look at the discuss patient's perception and look at the effects on their lifestyle. Yeah. So that's very important too. Provide education, like I said that they can use the SABA, the short-acting one, before the exercises induced. So space periods of activity and rest, assessed with ADLs, and determine suitable activities based on the asthmatic events. So how do we know it's getting better? Their O2 are good, they're having fewer attacks, okay? The other thing is when you are going to evaluate for somebody for asthma and see that how they're getting better, look at their sign and symptom. Did they come into their persistent severe? You want to say them going down, okay? From persistent moderate going down to mild, okay? From persistent they're going to injure. So that means they're getting better. So if they go downhill from the steps, getting better, if they start going up, that means they're getting worse. Any questions?